Thanks for joining in for the grand rounds this morning. My name is Abhi Kasinadhuni. I am a graduated fellow from the CVR Fellowship. I am about, I would say, one and a half years into practice at the King of Prussia and Wayne locations, for those of you who don't know me. And it's been a great ride so far. And all right, let's go ahead and get started. So today I will present on the topic of the current concepts in the management of perforator disease. The whole point of this presentation is really to gain an understanding of perforator vein disease and some of the latest advances in the management of it. So chronic venous insufficiency is prevalent worldwide. Both deep and superficial venous reflux can cause not only chronic venous insufficiency, but also ulceration, which is a huge risk for infection, pain, and disability. Compression has historically been the primary therapy for CVI, but treatment of underlying vein disease, has come to light to relieve venous hypertension, and it appears to improve wound healing and decrease reoccurrence. The latest clinical practice guidelines by the Society of Vascular Surgery and the American Venous Forum, established in 2014, recommend treating perforator veins that carry a reflux time of greater than half a second and a vein diameter greater than 3.5 millimeters. And this perforator vein or these perforator veins must be located near healed or active venous ulcers. So these guidelines recommend against treatment of perforator veins that are in SEEP class 1 and class 2 patients. And we know that the value of perforator treatment in SEEP class 3 and class 4 disease still remains unclear. The modalities available for treating perforator veins include subfascial endoscopic perforator surgery, or the acronym for it is SEPS, open perforator surgery, sclerotherapy, and thermal ablation. There are a couple of others. I'll go into those as well later in the presentation. So let's touch lightly on the anatomy and physiology here. Lower extremity venous anatomy consists of deep, muscular, perforator, and superficial veins. As you can see in the picture here, the perforating veins connect the superficial and deep systems and are a part of the normal anatomy. Perforator veins demonstrate bidirectional flow in the calf as the muscles contract. The whole point of perforator veins is to get flow from the superficial system back to the deep system. They also relax to equalize the pressure between the deep and superficial systems. I have here in this slide a list of notable perforators. We won't go into all of them, but I will touch on a few of these that are more prominent. So the posterior tibial perforators, you can see here in the left picture, or also on the right, the Cockett perforators connect the posterior accessory great saphenous vein with the posterior tibial veins. The Cockett perforators are at the level of the calf and the inferior 2/3 of the leg. Cockett perforators were further subdivided later upon discovery into the superior, medium, and inferior perforators. Perforator veins of the medial region below the knee are the Boyd's perforators, and they open into the posterior tibial veins or even the tibioperineal trunk. And you can see a little bit of that pictured in both of the pictures again. And finally, the perforators of the femoral canal. And these were previously referred to as the Dodds and the Hunterian perforators. They connect the great saphenous vein and femoral veins. So now that we've seen what a normal perforator looks like, let's talk about the pathology behind it. The etiology of venous reflux in superficial and perforator veins is largely unknown. The most predominant theory so far is that the weakening of the venous wall, which leads to valvular failure, can lead to disease. At the earliest stages of disease, reflux is most prevalent in superficial veins. However, reflux in the perforator veins is defined as outward flow from the deep to the superficial systems. And so it's been suggested that this high flow from the deep veins during muscular contraction eventually creates this incompetence within the perforator veins. Some of the other leading scientists have suggested that the reflux in perforator veins is also due to the volume overload at the re-entry points of incompetent superficial veins. So, but thus far there isn't any direct evidence for either of these theories. A lot of it's lacking, mostly because the investigations that have been done so far have just been cross-sectional population studies, and not nearly enough longitudinal studies have been done on the disease and its progression. But I will touch on one study here by Nikos uh, Labaropoulos. I'm sorry, I know I didn't say that properly, but a very prominent investigator in in the world of phlebology. So Dr. L here and his team put together a prospective study to understand the patterns of reflux development in perforator veins. This article was published in the 2006 edition of the Journal of Vascular Surgery. And so, actually, I'm sorry, let me go back. So let me talk more about the study. So I'm going to talk about the results here. So the total number of patients that were studied in this investigation was 127 patients covering 158 limbs. There were 29 limbs, or about 18%, that developed reflux in the perforator veins. So in total, about 38 new incompetent perforator veins were identified during this study. The median time for the examination was about 25 months. So, and that ranged anywhere from 9 to 52 months. And reflux in a previously normal perforator vein at a reentry site was detected in about 15 veins, and in an ascending manner from an extension of superficial venous reflux in about 18 veins. So just to rephrase that, about 15 veins we saw perforator vein reflux at the reentry site, and in about 18 veins we saw it happen in an ascending manner, and this was from an extension of the superficial venous reflux, and in a new previously intact location in 5 of the veins. So what they concluded in this study was that reflux in perforator veins develops in ascending fashion through the superficial veins at reentry points and also at new sites. And worsening of the CVD is observed with new perforator vein reflux. But many other factors may play a major role, and therefore cause and effect association was difficult to prove. A really important observation that they made was that in all of the 5 sites, deep vein reflux was not present at the time of the first duplex study. And when the perforator vein connected to them was still competent, it seemed to have developed simultaneously with reflux, uh, you know, with reflux development in the perforator vein that connected to it. So I guess the point is that uh, superficial venous disease is strongly tied to the progression of perforator vein disease. And in a lot of these um, initial studies, deep vein disease was not present. And so that's a very important observation. And it suggests that deep vein disease can develop later as a consequence of the superficial and perforator vein disease. And so a few guidelines for treating perforator veins: failed compression therapy, axial reflux that has been fully treated, as mentioned before, diameter of 3.5 millimeters and reflux time of half a second. And Medicare's guidelines for the treatment of perforator veins include, they allow either foam sclerotherapy or thermal ablation, and it will be considered medically reasonable and necessary when, I mentioned this before, you have an active ulcer or a healed ulcer in close proximity to the incompetent perforator vein. Or you can have proximal significant reflux that's been treated, and yet a perforator vein still persists under or adjacent to a healed ulcer. The proximal and regional venous reflux has been treated, and there is a persistent focal pain and tenderness, or even stasis dermatitis overlying the perforator. And lastly, uh, if the incompetent perforator demonstrates reflux over half a second and the diameter is over 3.5 millimeters. And I admit, when I went over these guidelines, I realized that, uh, I mainly treat perforator veins in my practice if there's an active or healed ulcer, but I've, since doing the research, been more careful to understand a patient's, you know, symptomology if they are having this focal pain, because, a number of patients we don't necessarily document perforator reflux if they don't have the C5 or C6 disease, right? And so this might be something, worth considering in patients that have this persistent pain or tenderness. Another study that I do want to touch on is the current state of treating perforator veins. This is basically a guidance that's been set forth, uh, by the Society of Vascular Surgery, the American Venous Forum, and it's pretty much in agreement with what I just mentioned. Current recommendations include perforator vein closure in SEEP classes 5 and 6 via percutaneous thermal ablation, subfascial endoscopic perforator surgery, open surgery, or sclerotherapy. Uh, they say that closure rates for thermal ablation have been reported between 60 and 80%. I'll touch on that lightly later. More recanalization and de novo perforator formation have been reported than after thermal saphenous closure, and ultrasound guided foam sclerotherapy has shown promise in perforator closure and wound healing, but with variable success rates. Again, I'll touch on that later. But they do say, regardless of the method used, successful closure of perforators appears predictive of wound healing with minimal morbidity. So let's go over the modalities. I guess this is what we're really here to discuss. The first is one of the older techniques. Dr. Hauer of Germany developed the technique of subfascial endoscopic perforator surgery, or SCPS, in 1985. And this approach really became popular between the years of 92 and 2008. It became the technique of choice for perforator ablation, primarily because of the reduced rate of wound complications. This technique is performed under general or epidural anesthesia, and either a single or double endoscopic port technique can be used for the dissection and division of medial calf perforators. Most of those that were performing this surgery use balloon dissection, carbon dioxide insufflation with a pressure of 30 millimeters mercury, and a pneumatic thigh tourniquet inflated to 300 millimeters mercury to avoid any bleeding in the surgical field. Followed by that, a division of the fascia of the deep posterior compartment with a peritibial fasciotomy is done. And this is to expose and identify the most important medial perforating veins. And then, so the most key portion of this is the occlusion of the perforators, which can be done with endoscopic clips. This is just a picture kind of outlining what I just mentioned. Here in the first figure on the left, you can see a division of the high cocket perforator with endoscopic scissors after the placement of vascular clips. I mean, it's a little bit harder to make out, but you can see that vascular clip, right above that scissors. Figure 2 on the right, you see a full view of the subfascial space after clipping a division of the medial perforating veins. And so those arrows are pointing to those surgical clips. Actually, let me go back real quick. So just, there is a North American SCPS registry that reported the results of SCPS performed in 17 centers across the United States, and the registry contains about 155 limbs. 85% of those folks had C5 and C6 disease. And so ulcer healing at 1 year was 88%, with the median time to ulcer healing at 54 days. Reoccurrence of ulcers happen happening was 16% at 1 year and 28% at 2 years. In this particular registry, there were 27 patients with class 6 disease who went through SEPS alone, and 78% of the ulcers healed. Uh, I guess one of the things they found out here was it's always superior to do superficial venous ablation prior to this SEPS surgery. And, the ulcer reoccurrence rate was higher in those who received SEPS alone. Prior to this SEPS technique, the approach was just open ligation via a modified Linton procedure. The surgical treatment of incompetent perforator veins has been reported to give good results in the healing of venous ulceration. But mainly, we're mainly concerned about the wound complications that occurred subsequently, and that's why these surgical procedures have mostly been abandoned. There was a prospective randomized trial that was started in about February 1994 to determine the wound complications, the healing and reoccurrence rates after open surgery versus this, newer minimally invasive approach. The study was actually discontinued because there was a high morbidity rate uh, with the open surgery. But they initially anticipated that about 80 patients would be included in the study, but that didn't happen. They ended up performing an analysis on about 39 patients, and even the authors of this study realized that this was a really small number, but they thought that the long-term results were worth publishing. And you can see them here that compared to the minimally invasive approach, that the modified Linton procedure had significantly higher, post-op wound infections. And, this is key. And I guess this is one of the reasons that, again, that surgical procedure was mostly abandoned. So the more important procedure that's relevant to perforator closure is radiofrequency ablation. So the particular paper that I read that discussed the success rates and the outcomes basically outlined this data here, which shows that 642 ablations were performed over 6 years with an initial success rate at 65%. Recanalized perforator veins were noted in the remaining 226 procedures, or 80 patients. Among them, 52 patients were clinically asymptomatic and hence not treated. Repeat ablation was performed in 52 symptomatic, incompetent perforator veins, or in about 29 patients. And the success rate upon repeat surgery or repeat closure was about 67%. The closure rate at 24 months was 65%. And, most importantly, there were no complications, or sorry, I take that back. The complication rate, including DVT, was less than 1%. And so I guess the point here is that the rates of successful closures for incompetent perforator veins on initial and redo procedures are pretty comparable. And the data does validate the utility of performing repeat ablations. It does suggest that the temperature of the radiofrequency catheter does matter, and the location of the perforator veins may be predictive of a successful outcome or recanalization. Also, the size of the perforator vein may be relevant here. So covering ultrasound guided foam sclerotherapy. So prior to RF, this is something that was studied and mostly for its minimally invasive nature. So this particular study, or this paper that I read, covered about actually I don't have the number written here, but the data shows that about 30 limbs, or 31.5%, had a previous GSV procedure, surgery, or ETA, and 1 to 4 incompetent perforator veins were treated per limb. The ultrasound guided foam sclerotherapy of the perforator vein using 2 to 6 milliliters of 1 to 3% polydocanol was utilized in about 82.2% of the patient population. and STS in about 18% of the population. Um, what we really found here was that the occlusion rate at 1 month was around 98.6%, but dropped to a whopping 58.5% at 1 year. Three of the patients required a second procedure, and clinical improvement was reported in about 96.8% of the patients at 1 month and about 77% at 12 months. So this paper demonstrated that successful occlusion was possible with ultrasound-guided foam sclerotherapy, and that, again, the perforator vein diameter had a direct relation to the success rate. So let's compare the modalities that exist that are most popularly used, RF versus laser versus foam. So this particular paper discusses these three modalities. The closure rates in ultrasound-guided foam they established was about 57%, 73% with RF, and 61% in the laser group. RF was found to have a significantly better closure rate than foam, and in relation to this, SEEP class was not found to be a significant predictor of closure. All the comparisons showed no effect of energy used on closure rates. And when patients were first treated with foam and closure failed, there was a significant improvement in closure rates when it was followed up by a thermal ablation. The laser closure rate after ultrasound guided foam failed, improved to 85% and 89% when RF was used the second time around. There was no improvement in the closure rate of the second foam if the first foam failed. So in other words, if foam failed the first time, the recommendation is to go with thermal ablation. And so this study compared these three modalities. RF was found to be the most reliable means of perforator closure, and they found that morbid obesity, or basically a body mass index of greater than 50, predicted failure of perforator closure in all the groups, and failure of foam as initial treatment led to increased perforator closure when thermal ablation was used as a secondary technique. So, I want to move on to the SECURE trial. This was, a trial that was led by Kathleen Gibson and a few other very prominent folks. The objective of this study was to evaluate the safety and efficacy of, endovenous laser therapy using a 400 millimeter fiber to treat the incompetent perforator veins. It was a single arm prospective 7-center study. It was non-blinded, and it basically examined patients with advanced skin changes or healed or active ulceration. So basically C4B, C5, and C6 disease. Patients received a treatment with a laser fiber that was 1470 nanometers, and the efficacy population included were 83 patients with a total of 125 pathologic perforator veins. And so the key findings for this study include, perforator vein closure rate at 10 days after treatment, and that rate was 76.9%. Successful primary closure rates of 75%, 70%, 62%, and 68% were achieved at 1, 3, 6, 9, and 12 months. So basically, at 1 month, we observed about 75% closure. And by the time we ended up at 12 months, it dipped down to about 71%. These were statistically significant numbers, and they were seen in patients. So when they measured quality of life, they saw that the quality of life did improve from 1 month to 12 months, when comparing the numbers, and the ulcer healing displayed improvement during the course of this study. And so the conclusion here is that laser works, it was safe, and the outcomes showed that they were effective with no major adverse side effects. And so this last slide, again, when we're comparing these modalities against each other, We can see that with RF, the complications or the adverse effects were pretty minimal, and they are what you would expect. Some nerve injury or nerve pain, chemical ulcer, cellulitis, DVT, phlebitis. In the laser group, we saw that 3 of the patients had paresthesias, and the foam group, the DVT rate was closer to 3%, which is significant. Lastly, we have the cyanoacrylate, a modality, which is less discussed and less studied as it is a newer modality. There was this CAPE study basically assessing cyanoacrylate adhesive for perforator embolization. And so what we found is that, we know that CAA is a non-thermal modality that does not require anesthesia. So there is the benefit, and the study explores the feasibility of cyanoacrylate. And the results showed that a 76% occlusion rate was achieved without any serious complications. And this leads to the conclusion that a dedicated delivery device in a larger patient population is warranted, and that's something we need to consider. I know that at ABLS this year, there were some folks from, I believe, Florida, and I'm failing to recall the name. Maybe it's, yeah, anyway, a group of folks from Florida who are attempting to publish data on the same, on the advent of cyanoacrylate for perforator closure. So this is something that certainly needs more, needs more attention. And so that's all I have today for the concepts. So thank you for tuning in this morning on a Friday. Does anybody have any questions?
Hey, Abhi, that was really good. Thank you for doing that. Great job, as always. Quick question for you. So when you have a patient with a perforator that has an ulcer, is your preference laser or RFS? And is there any implications in terms of coverage for the payers at all?
Yeah, so in Pennsylvania, I read the Medicare LCD, and that's pretty much consistent with what we have there. My preference is usually for laser for 2 reasons. One, we actually just don't have RFS catheters, we don't ablate perforators frequently enough that we've requested them. So the laser is ready on hand, and so it's preferred for that reason. But also, I feel that there's some more flexibility with the laser, because if we do have shorter perforators, or maybe certain perforators that are a little bit more difficult to access, using that 16 gauge to get into that perforator has been a little easier for me, and so I've had a higher success rate. I did play with the RFS during my fellowship a couple of times, and it's a great modality when it's available. Outside of those modalities, I haven't really attempted much else. There were a few scenarios where we did utilize foam, when we were basically simultaneously treating the superficial veins. We did try to utilize the foam, mostly because we found that the coverage was not necessarily there, and this was mostly in commercial patients, because they might have not had active ulcers, yet they had residual symptoms despite treatment of the axial veins.
Thank you. And the other thing is, guys, the Kathy Gibson is also doing some perforators with Venaseal now as well, so cyanoacrylate glue. So that's also one of the newer techniques. I don't think that's FDA approved yet, but she's had great results with the glue, and that's obviously a lot of times when we're ablating down below the mid calf. Obviously, there's not much tissue there, not much fat. That helps with not having to mess, and the results have been good there. So hopefully we'll get that approved relatively soon as well. And any other questions, guys, at all?
I had one question, Dave
Yeah.
Calcagno. I'm not familiar with doing the ultrasound guided foam. For the perforators, I usually do the RF. I noticed that the published series, the DVT rate was only 3%. If for anybody in the audience that does this a lot, it seems like it'd be hard not to get DVTs if you're injecting foam into a perforator vein. Are you injecting the tributaries to the perforator, or how do they keep the DVT rate so low?
Well, I'm not certain in the paper. The paper doesn't really discuss the modality, but some of the other papers that I've read on technique suggest that they inject anywhere from 6 millimeters upwards up to 10 millimeters of foam in and around the perforator site, sometimes directly into the perforator site. And immediately following injection, they apply pressure for at least 10 seconds. And somehow they've managed not to have a high DVT rate. I found this surprising too. The few times that I've done it in these patients that I could not perform a thermal ablation, I usually do it around the perforator site, not directly into it, knowing that it's going to end up there anyway. And so I'm cautious on how much that I use. And then, I immediately, dorsiflex the foot and apply the pressure as well. And so far that's worked for me, but that doesn't necessarily mean it reduces that rate of,
Hey, Abhi, years ago, here in Maryland, Aetna had a policy of perforators to be treated with foam, and found myself, and at that time we felt the need. We were treating a lot more perforators before so much of this data came out. I'll tell you, I was very surprised too. Every time I did it, I held my heart in one hand and the syringe in the other. I know it was, but the rate of DVTs was very low, minimal really. But I was also very, very cautious in terms of the volume, and that was with STS.
Hi, Abhi, this is Zoe. Oh, sorry. Go ahead.
Hi, this is Luis. I just had a quick question about purchasing. Are we able to purchase 2E bores? They're like a lock mechanism that can attach to the 16 gauge needle, and also.
Yes, Luis, you can definitely order them. That's be on our order form, and if it's not,
okay, great.
Just let your ROD know.
Yeah, I was just going to comment on the ultrasound guided foam for perforators. I used to do a lot of this when I first started, and we just inject a trib at a little bit of a distance, and just like we do now when we hold the perforators, where it connects to the deep, I would just press there. And it seemed to work really, really well. And it really was a low incidence. And I think you get a spasm of the perforator when you're first injecting the trib into it. But, I hear what you're saying. I don't know why, but I have gotten away from doing perforators on the first round of treatment and have started doing the superficial and then bringing them back for their 1 month or 3 month and then reassessing the perforator then. And depending on the kind of perforator, whether it was an antegrade or a retrograde or blowout from a deep system, if it was deep, then it's going to still be there. And now I traditionally will take those patients and examine their pelvic veins rather than doing the perforators first. So I tend to have push the perforators way to the back of the line and find that a lot of these, when you correct the underlying problem, they do correct.
So as always, Zoe is absolutely correct. Most of us are injecting, right, a tributary that's very close to the perforator, and you're compressing the perforator at the time of the injection, so very little foam gets in there. And then the thought is that the flow through the deep system is so great that it deactivates the foam. So by the time the amount of foam gets in there, very, very little of it activated. And that's the reason why the DVT rate for ultrasound guided foam sclerotherapy is so low for perforators if you're injecting them now. But the real reason why we don't do ultrasound guided foam sclerotherapy
for perforators is mainly because the recurrence rate is so high, right? The failure rate for ultrasound guided foam sclerotherapy is significantly worse than it is for thermal ablation. So that's the real reason for not doing it. Okay. Hey guys, it's 7:36. Unless there's any other questions, have a good weekend. All right. Take care.
Yep. Thanks everyone.
Great job, Abhi.
Great job, Abhi.
Appreciate it. Thank you.